I thank you to the organizing team for the chance giving me.
Okay, we can't hear you and we can't see the screen.
Can you
Now,
can you see this? Can you see
now we
the
can see
screen?
them. Yes.
Okay. Okay. So today's my topic is melioidosis, a mimicker of tuberculosis. It is a diagnostic challenge to microbiologists as well as pathologists. The aim of the presentation to evaluate cases of melioidosis which were wrongly diagnosed as tuberculosis, and to discuss the major comorbidities the patients have, and also to discuss the need of awareness on the prevalence of melioidosis in geographical places or geographic area where it is not described as endemic. The people are not aware that it is endemic. Introduction. What this is, melioidosis is an infectious disease caused by a saprophyte called Burkholderia pseudomallei. Burkholderia pseudomallei is a gram-negative saprophyte and facultative intracellular bacterium, which was first reported by Whitmore in 1911 from Burma. The bacteria have access to the human body by inhalation or incidental inoculation or even by ingestion. And the bacteria has got some properties like it can be internalized by host cells, and there are some receptors on host cells, and this bacteria can attach to the receptors and get internalized. Pseudomyelium, Burkholderia pseudomyeli can infect a wide range of cells, human cells, including macrophages, monocytes, neutrophils, as well as non-phagocytic cells. Once internalized, there are some secretion systems present in the bacteria. No, it can, particularly the type 3 secretory system, can facilitate the bacteria B. pseudomyeli to escape from the phagosome. So it is not uh, um, destroyed in the phagosomes, and it replicates in the cytoplasm. And another secretory system, that is T6, of this 5 of the T6 facilitates the host cell membrane fusion, and there is multinucleated giant cells. This occurs usually in the chronic infections, chronic cases of melioidosis. And also it can remain latent. In some patients, no, the bacteria is infecting, and it is there inside the cells, reticuloendothelial cells, and it can remain mainly reticuloendothelial cells. What other cells infected, it is not known. The infection may be asymptomatic and the pathogen is not cleared. So it can remain dormant, and later it can be reactivated and causing infection or disease, I think. So the two cases I want to describe, which were wrongly diagnosed as tuberculosis and treated with anti-tuberculosis drugs, and they developed complications. The case one, the patient was a middle-aged diabetic man who was admitted with the fever, cough, and weight loss. So all these symptoms in our place, no, we first of all suspected tuberculosis because it is the duration is more than 1 month, and radiologically the there was poorly defined linear and nodular opacities in the superior segment of right lower lobe, and these findings are suggestive of tuberculosis. Radiologically, the patient was diagnosed as tuberculosis, And the physician gave anti-tuberculosis treatment for the patient. Within 1 month, patient was taking these drugs, and he developed the symptoms. Means the patient developed septicemia, and other symptoms also got worse, and the cough, fever, like that. And patient was referred to a tertiary care center. I am stressing this tertiary care center because the this all this occurred in a periphery hospital, no. And in that center, the bronchoalveolar lavage, BAL was collected, and the sample was evaluated for tuberculosis, the presence of acid fast bacilli, and the culture. Nothing was there suggesting TB. And the routine culture yielded Burkholderia pseudomallei. This is the colony appearance. The peculiar colony appearance, um, the dry colonies on both. Routinely, we are using Mekong agar and blood agar for a routine culture. Um, and this appearance, on Mekong agar, they are non-lactose fermenting colonies, a dry appearance. And there is a sheen, yes, I think a metallic sheen for these colonies. And on this gram stain, typically the bacteria is described on gram stain as gram negative, but it is a bipolar appearance. Bipolar appearance means the condensation of the stain on both poles, and the center is seen empty, as empty. So this is the typical appearance of Burkholderia pseudomallei. And in the routine culture, we got this growth, and patient was treated successfully with the ceftazidime in intensive phase, because these patients need uh, treatment in two phases: the intensive phase as well as the eradication phase or maintenance phase. In intensive phase, the bactericidal agent is given, usually the ceftazidime. This is the drug of choice, or we can give the carbapenem like meropenem. And in the maintenance or eradication phase, so the cotrimoxazole or amoxiclav. In this case, we give both cotrimoxazole and amoxicillin clavulanic acid combination, or we can even give doxycycline. Later, see, the patient needed resection of the affected lobe. That was he had a big, large abscess in that lobe. The second case was a 60-year-old lady who was on treatment for psoriasis and developed left inguinal lymphadenitis. It was the infection of the lymph node. And again, histopathological examination showed a granuloma suggestive of tuberculosis. And again, she also was treated for 1 month with anti-tuberculosis treatment. She developed abscess in that region, and the pus sample in the microbiology lab yielded Burkholderia pseudomallei. Accordingly, patient was treated with again in the intensive phase as with the ceftazidime, and later with cotrimoxazole. So, about two cases received treatment from healthcare facilities where physicians were not aware of this entity. To discuss, melioidosis is nicknamed the great mimicker because of the non-specific signs and symptoms which can often hinder the diagnosis and management. Because it can be acute case. Acute case means patient may be coming with some pneumonia and septicemia, or it can be subacute, maybe an abscess somewhere in the soft tissue, or just like TB, like the chronic and TB like appearance. And acute melioidosis will present as sepsis with or without pneumonia, localized abscesses, regardless of the route of infection. So, acute and chronic or chronic inflammation may show focal granulomatous component. You can see the multinucleated giant cells or maybe purely granulomatous. So, pathologists may give the impression or may get the impression as tuberculosis and reported as tuberculosis. Chronic tuberculosis the symptoms last for more than 2 months, but patients may not be remembering that for how many days or how many weeks he or she was having symptoms. 11% of individuals infected with the Burkholderia pseudomallei will go for chronic melioidosis. Chronic case of melioidosis gives a picture of tuberculosis in radiological as well as histopathological examinations. Not all cases. Problem is with non-endemic areas or even it is endemic, but prevalence is unknown. Just like our area, the prevalence is we don't know what is the exact prevalence in our area. The reported cases may be tip of the iceberg. Patients are treated for tuberculosis and they develop complications. So, about 2 cases were first diagnosed as tuberculosis and treated as tuberculosis. This is due to the lack of awareness of this disease among physicians as well as laboratories. Well, even the laboratory physicians may also miss the case. So the appearance may be a typical granuloma, just like the first picture, or it may be a foreign body inflammation. I mean, only the multinucleated cells may be there, but it may not be typical. Um, may be reported as foreign body granuloma like that. So pathologists may be tuned like that. Can be tuberculosis. So they are reporting as tuberculosis. And usually the patients, usually majority of the patients, means 80% of the patients have comorbidity. Mainly of this 50% have diabetes. Risk factors, other risk factors are hazardous alcohol use, chronic renal disease, chronic lung disease, maybe malignancy or rheumatic heart disease or cardiac failure. And age is also a factor, like more than 50 years, people are more prone to get infection. So, in one of our studies, we studied, we got 72 patients with melioidosis. We could prove it by microbiological culture. It was an 8-year study, and of these, 76 patients were diabetic. So the underdiagnosis and underreporting of melioidosis are a major issue due to lack of awareness among physicians, pathologists, and laboratory staff. In India, in a prediction study, we are it is predicted that we should get 52,500 cases per year, but very less. Even worldwide, only 1%, up to 1% melioidosis is reported. In microbiological laboratory also, the pseudomyeli sometimes discarded as contaminant because the rough colony's appearance, it may resemble other bacteria like Pseudomonas or even the spore bearers like Bacillus. So it is discarded. And some cases, the bacteria may take more time. This bacteria can grow on single media, but they may take time more than 48 hours. So when the laboratory people are not aware of the condition, no, they will keep the culture plate for 48 hours and they will discard the plates without seeing any growth. Usually, it should be in our laboratory. We keep it for 3 days if we suspect melioidosis. And similarities of chronic cases of melioidosis and tuberculosis in radiological and histopathological examinations may mislead the physicians. So, without microbiological evidence, they will treat the patient as tuberculosis. Problem is mainly with the non-endemic areas as well as the endemic area, but the reported case of prevalence is not known. So the measures should be taken to reduce the underdiagnosis. So for that we have to do a simultaneous microbiological evaluation, and laboratories should be aware that isolation from any clinical sample should be regarded as diagnostic of melioidosis. Means uh, what will happen now that in some cases the blood cultures, we are taking two samples but one sample only may yield this growth. In that case some people, so two samples haven't grown the growth, so one sample only may be contaminant, like that it may be discarded. And blood cultures are the most important for any patients. If we suspect melioidosis, the blood culture should be taken. Bacteremia is very important in this melioidosis, and also the other samples like a throat swab or even urine sample can take, or stool sample. Any sample we can take, and if we see a single colony of melioidosis, we have to uh, take it as significant, because melioidosis, the Burkholderia pseudomyeli is not a commensal, or it does not occur as contaminant. To overcome this, because culture will take time, and cultures may be discarded as a contaminant, so we can use some rapid tests like lateral flow immunoassay. But again, the sensitivity may be poor. It needs more study for this rapid test. So we need in our place epidemiological study. Knowledge on prevalence is very very important, and also the environmental sampling. We have to do the soil testing, because it can be there in the soil up to 10 centimeter. It is there in the rhizosphere, and it may come out during rainy season, and our place is with a lots of rain, monsoon. So and people who are working in paddy fields, they are more prone to get infection by this bacteria. So environmental sampling we haven't done in our place. It is very very important. So to conclude, not all granulomas are tuberculosis, because granuloma can occur in any chronic infection, like even non-tuberculous mycobacteria can form granulomas, and this melioidosis also can form granulomas. So all this should be considered. Diagnosis should be based on clinical, epidemiological as well as bacterial culture, and treating physician as well as laboratory physicians should be made aware of this condition. All pathologists should be aware of this condition. Whenever they see a granuloma, should not be stamped as tuberculosis. So these are the reference. Thank you. If any questions, please.